You know, evaluation is maybe one of the most fundamental, natural human acts, isn't it?
It really is. We're constantly doing it without even thinking.
Exactly. I was reading this quote from the researcher Emil Posavec, and he put it so simply. If you're a chef, you taste the soup before it goes out.
Mm.
If you're a basketball player, you watch the arc of your hook shot to see if it's going in. It's that, that simple, immediate feedback loop.
And that's our basic mechanism, right, for knowing if we're succeeding, if the quality is there.
Yeah.
But, and this is the big but, that simple concept it completely breaks down when you try to apply it to something like healthcare.
Because it's not one person shooting one ball.
Not even close. It's what Rossi and others called a team sport. But it's a team sport being played in a really high-stakes, resource-constrained, and frankly, often fragmented environment.
So success is never as simple as, a ball going through a hoop.
Never. The outcome, the patient's actual health, is the result of just countless, complex, interacting variables. It's a web, not a straight line.
Okay, so let's really dig into that inherent complexity. For this deep dive, we're going to unpack the material on these seismic drivers that are just completely remaking the healthcare landscape.
Right, and more importantly, why measuring quality, that essential act of evaluation, has become so incredibly difficult.
It seems like one of the most, intellectually daunting challenges of our time. So evaluation, in the formal sense, it really has two core components.
It does. First, you need a detailed, objective description of what happened. The performance, the outcome.
Just the facts.
Just the facts. And second, you need the established standards or criteria you're using to judge that performance. You need the yardstick.
And that distinction is it's vital.
Oh, absolutely. As Rossi and their colleagues documented, the whole point of evaluation is to inform and support decision-making.
Based on good data.
Based on relevant high-standard data.
Yeah.
But, when we talk about healthcare, it's often been described as maybe the single most complex system humanity's ever created.
I've heard that, yeah.
And its dynamic nature, the fact that it's always changing, doesn't just, intensify the evaluation challenge, it almost destabilizes it.
Because the ultimate question, the one that decides if we fund a program or adopt a new standard, is always the same.
Always.
Does the evaluation actually capture a real difference in the quality of care for patients or for entire populations compared to what we're doing right now?
And if you can't answer that with confidence, you're just guessing.
You risk making these incredibly expensive, high-stakes decisions based on, guesswork.
You do. So our mission today is really to analyze these forces at play. The sources we're looking at identify 8 specific interconnected drivers of change.
8 of them.
And they're forcing everyone, providers, policymakers, and you, the listener, as a consumer, to operate in totally new ways. We need to look at how these drivers were accelerated and then really confront this grand challenge of measurement.
All right, so where do we start? I think we have to start with the one event that just overshadowed everything else, the catalyst.
The one that didn't just cause change, but actively amplified and distorted every other driver that already existed.
But before we jump right into that mega driver, you mentioned something about evaluation models themselves. They're not like models in, say, physics, are they?
Not at all. That's a great point to start with. In fields like physics or engineering, you expect a model to have a high degree of precision. If you put A into the system, you expect B to come out. It's predictable.
But healthcare evaluation is it's rarely that linear.
It's not. The models often lack that rigid formulaic precision. They offer general principles, not a step-by-step recipe.
So the person doing the evaluation has to be more of a custom designer.
That is the perfect way to put it. They have to customize the whole approach to fit the specific goals, the specific setting, whether they're looking at a single clinical team in one hospital or trying to get their head around the health of an entire population, an ultra-macro system level.
So they have to define what they're measuring and then find or even create the right yardstick for it?
More often than not, they're designing entirely new criteria. And just as this, very careful, bespoke process of evaluation was sort of trudging along, the ultimate stress test arrived.
The one that forced immediate system-wide customization whether anyone was ready or not.
Which brings us to driver 1, the COVID-19 pandemic. We just can't look at the state of healthcare today without seeing this as the mega driver. It was an unprecedented, devastating global crisis that hit everything at once.
It wasn't just healthcare.
No. It fractured healthcare systems, economies, schools, daily life, every continent all at the same time.
It really acted like a shockwave, didn't it?
Precisely. It didn't just add a new problem to the list. It fundamentally interacted with all the existing drivers we're going to talk about: policy, technology, partnerships. It revised some of them completely. It made others irrelevant overnight. And it created entirely new areas of focus we barely considered before.
It sounds horrifying, and it was, but the sources note that the sheer force of this disruption, it actually had some profoundly unexpected positives.
It did. It completely broke the stasis, that inertia that often plagues large bureaucratic systems.
It forced them to move.
The sheer force of the crisis compelled the system to shift from its usual slow, cautious, siloed approach to one that was intensely innovative, collaborative, and, this is a key word, nimble.
That kind of rapid change was frankly unimaginable just a year before it happened.
Unimaginable. And this atmosphere, it accelerated what we call disruptive innovation. New products, new processes, new ways of delivering care were replacing the old ones almost daily.
That rapid adoption is fascinating. I mean, traditional medical advancement can take a decade, right? Endless studies, peer reviews. How did they short-circuit that process?
They adopted what the source calls the just-in-time philosophy. It completely replaced that institutional caution.
So the requirement for, multi-year testing or demanding 100% proof of success before you try something.
Gone. It was replaced by a willingness to try new solutions immediately, as long as they seemed reasonable and necessary. And here's the other crucial part. There was an accompanying freedom to fail quickly.
So if it didn't work, you didn't spend a year studying why.
You aborted it and moved on to the next option immediately. That necessary flexibility just fueled innovation on the spot.
That kind of flexibility must have created a huge cultural shift around the idea of knowledge itself.
It absolutely did. It forced a new comfort level with what the source calls tentative knowledge.
Tentative knowledge. What does that mean in practice?
Well, think about the early days of the pandemic. The recommendations on masks were changing, right? The protocols for ventilation, the treatment ideas.
I remember it seemed like the advice changed every week.
Because it did. What was state of the science yesterday was being replaced by new incoming evidence today. We were all forced to accept the provisional, tentative nature of knowledge in real time. Practice guidelines were shifting weekly, sometimes daily.
Which means providers had to be in this mode of constant, aggressive self-education.
They had to be willing to abandon firmly held beliefs on a dime based on new data. It was a massive cognitive shift.
But, okay, this radical, rapid shift, it creates immediate evaluation challenges, right? Especially when you're looking at the whole population. If your data is tentative and the rules are changing daily, how do you generate reliable indicators of performance?
This is the evaluation challenge at that ultra-macro system level you mentioned. The common performance indicators we normally rely on they become instantly unreliable.
Okay, give me an example.
Let's say you want to evaluate the spread of the pandemic in a region. Relying only on the raw number of positive COVID-19 tests is not a good indicator of prevalence or severity.
Right, because testing access was all over the place.
Exactly. The more you test in a population, the more positives you're going to find, especially with asymptomatic cases. So you end up measuring testing policy and volume as much as you're measuring the actual disease.
So a comparison between a place testing 1% of its population and a place testing 10% is basically meaningless.
Without accounting for that denominator, yes, it's apples and oranges. And the same problem applies to your outcome metrics, like mortality.
A raw death count doesn't tell the whole story.
Not even close. Evaluating outcomes based purely on that raw number fails to provide the context you need for any real comparison or quality assessment. It doesn't tell you the age groups affected or the comorbidities, or critically, it doesn't give you a comparative denominator like deaths per 100,000 people.
Without that nuance, you can't judge whether one region's response was actually better than another's.
You're just looking at big, scary numbers without the context needed to make them useful. The complexity of the mega driver forces us to look way beyond simple arithmetic.
So this COVID earthquake didn't just shake the system, it forced immediate, unprecedented changes in how the rules themselves are written.
Which is a perfect transition, because that systemic need for nimbleness immediately ran headfirst into the rigidity of long-standing rules.
That brings us to driver 2, health policy and other policies. The major driver for change here seems to be this widespread recognition that inadequate or just outdated policies were creating these severe barriers.
They were barriers to progress, to equity, to resolving long-standing disparities in care. Pre-pandemic, our policies were built for peacetime. They were slow and deliberate.
And when the crisis hit, those rules were actively getting in the way.
They were. So policymakers at every level had to respond. The usual long-term cautious processes for approving policies, they had to give way to expedited innovative methods. The crisis basically provided the political and clinical cover needed to bypass years of institutional inertia.
So let's get into some concrete examples. Where did we see policy revisions happen the fastest? Let's start at the national level.
At the national level, the most visible example, without a doubt, was the expedited FDA review process, the Emergency Use Authorization, or EUA.
For new drugs, vaccines, tests.
All of it. And this wasn't just, shaving a few months off the calendar. It was a fundamental reorganization of the regulatory workflow that allowed promising therapies to reach patients in months, not years.
All under that framework of tentative knowledge we just talked about.
Precisely. And then inside the hospitals themselves, policies around the most basic materials were totally upended.
You're talking about PPE.
Personal protective equipment.
Yeah.
Organizations had to immediately rewrite their internal policies about reusing and conserving PPE for frontline providers, simply because the supply chain had completely failed.
And what about patients? The policies for admitting them had to change too, right?
Absolutely. Admission and discharge policies had to be adapted on the fly for patients being moved into these specialized, often temporary high-acuity COVID units. Sometimes they were in converting conference rooms or cafeterias. The old rules just didn't apply.
And then, critically, this acceleration pushed into areas that are usually fiercely resistant to change: professional licensure and education.
Oh, this was a huge one. Think about the requirements for nurses and physicians to get licensed. Many state boards had these fixed numbers of direct patient care hours.
And when clinical sites shut down?
Those policies became impossible to meet. They had to be modified instantly. Boards started accepting virtual clinical experiences, high-fidelity simulation, even teleproctoring as substitutes for traditional hands-on care.
That's a radical shift in educational policy.
It opened the door for competency-based models that we'll talk about later. And the crisis also forced changes to scope of practice, which is usually the source of these intense professional turf wars.
Right. Who's allowed to do what?
Exactly.
Yeah.
Scope of practice policies were revised to allow non-physician providers, like nurse practitioners and physician assistants, to take on greater, more independent clinical responsibilities.
Which was a practical response to the massive provider shortages.
It was. And it provided real-world evidence that these expanded roles could be executed safely and effectively. But maybe the most enduring policy change was the one around digital health access.
Telehealth. For decades, getting universal reimbursement for it was a losing battle.
It's the perfect illustration of how the mega driver just shattered an embedded barrier. Medicare and private payer policies were revised almost overnight to pay for telehealth visits.
Because during quarantine, it wasn't just a convenience, it was a necessity.
It was essential for continuity of care, especially for vulnerable populations. All those past legislative attempts had stalled, but the crisis forced the change. And now that the door is open and the technology has proven effective, you can't just close it again.
So these policy shifts exposed and really forced organizational leaders to confront these severe systemic shortcomings, that's driver 3, organizations and systems. What were the core organizational drivers already in play, and how did the crisis just pour gasoline on them?
Well, the core drivers for organizational change before the pandemic and now are really unacceptable outcomes on existing quality measures and the absolute fiduciary need for improvement.
They need to do better.
They need to do better. But the impact of COVID on the organizations themselves was just profound because the executive management teams were facing catastrophic losses in every single area of their enterprise all at once.
What do you mean by every area? What were those immediate losses?
Okay, so first they had massive personnel losses. Staff got sick, they burned out, they retired. Then clinical capability degradation. Elective procedures, the high-revenue stuff, were shut down.
So expertise and specialized facilities were just sitting idle.
Or being repurposed.
Yeah.
Then you had catastrophic supply chain failures. I mean, basic things like gloves and masks just disappeared. And all of this translated directly into devastating financial losses.
Because the high-revenue procedures stopped while the complex, low-reimbursement critical care just surged.
Exactly. This wasn't a business challenge. This was a total organizational restructuring event happening in real time.
The ultimate stress test for resilience.
It was. It required immediate action, not just to care for patients and employees, but to fundamentally rethink the entire financial and service delivery model. It forced organizations to shift their focus from high-volume care, what makes the most money, to high-value care.
Focusing on improving outcomes while controlling costs.
A shift from volume-based to value-based care that had been theoretical for years suddenly became a financial and operational imperative.
And this incredible pressure, this necessity, it actually created an opportunity for leadership.
A massive one. Leadership teams and national organizations now have this powerful, shared mandate to collaborate and align in creating the future of healthcare. The crisis was so overwhelming that it just shattered the traditional institutional silos that held the system back.
It forced systems to actually merge knowledge and resources.
It did. And that forced collaboration feeds directly into our next driver, which takes the focus beyond the hospital walls and out into the patient's own neighborhood.
Driver 4, population health. What is the guiding force here? What's pushing this forward?
The central galvanizing force is the undeniable need to address disparity and ensure equitable care for all. The pandemic laid bare the fact that the sources of poor health outcomes are deeply, deeply rooted in issues of equity and socioeconomic disparity.
And that's why there's this renewed national focus on population health.
It is. And this concern is reflected in two long-standing guiding frameworks that organizations are now adhering to almost religiously.
Let's touch on those. There's the classic access, cost, quality triad, but also the Institute for Healthcare Improvement, or IHI framework, the triple aim.
The IHI triple aim is really the gold standard today. It requires health systems to optimize performance in three interdependent areas. First, improve the patient experience of care quality and satisfaction.
Okay.
Second, improve the health of populations. So moving the needle on community-wide outcomes.
Yeah.
And third, critically, reducing the per capita cost of healthcare.
And during the pandemic, all three of those aims were just severely strained.
Which forced organizations to re-envision their entire strategy. You can't just focus on treating illness when it shows up in your door. You have to shift upstream.
You have to move from what the source calls illness care to genuine health care.
Exactly, which includes proactive wellness and preventive strategies. And to do that, to achieve the population health component, organizations recognized this massive, underutilized link to the community.
Realizing that what happens in the 5 days a patient is in the hospital is less important than what happens in the 360 days they spend where they actually live and work.
That's the whole game. And this created entirely new types of partnerships.
Innovative partnerships aligned with big goals like Healthy People 2030.
We saw the inclusion of non-traditional stakeholders into the health delivery team. People like community health workers, who are so critical for bridging the gap between a clinical setting and the local culture.
And even other services like fire departments.
Fire departments, parks departments, schools, all working together to promote safety and health outside the four walls of the clinic.
And technology is really what allows those partnerships to function seamlessly.
Precisely. This outreach was coupled with a huge incorporation of informatics and healthcare, tech-sophisticated telehealth, wearable devices, smart home technologies, all used to monitor people with complex chronic conditions right where they live.
So by involving all these voices and leveraging technology, they can finally start to address healthcare for the diverse subgroups within a population.
And directly tackle those issues of equity and disparity at their source.
That leads us perfectly into the engine of modern transformation. If policy opened the door, technology just burst right through it.
Let's talk about the technological and collaborative revolution that makes all this new population-based care even possible.
Driver 5. Informatics and healthcare technologies. This is, it's unequivocally the engine of change in the 21st century, isn't it?
There's no question. Informatics, which is just the combination of information and communication tech with healthcare, it improves every single measurable aspect of patient care and system efficiency.
So when we talk about tangible benefits, what are we actually seeing?
We're seeing database electronic systems that significantly decrease medical errors. They get rid of messy handwriting, they improve prescription tracking, they reduce the time it takes from when the test is run to when a clinician makes a diagnostic decision.
So it digitizes and speeds up the process.
Dramatically. And it improves communication among multi-specialty providers. Put that all together and you get greater efficiency, better patient-centered outcomes, and crucially, improved safety of care.
This really all started with the digital revolution itself, that shift from clunky mechanical and analog tech to digital electronics. That's what allowed the system to even start collecting and analyzing big data.
It was absolutely foundational. The ability to manage these massive continuous streams of data allowed for safety to be monitored in real time, saving time, costs, energy.
Yeah.
And then COVID hit.
And instantly accelerated the adoption of this tech beyond anyone's prediction.
It was like hitting a fast-forward button. The surge in patient volume created this immediate need to drastically increase the efficiency and capacity of electronic health record systems, the EHRs.
They had to handle more data faster.
Way more. Higher volumes of complex admission details, treatment decisions, diagnostic actions, all at ultra speed. And the EHRs also had to be integrated with supply chain management to help track and mitigate those severe shortages of drugs and equipment.
And then, of course, there's the telehealth explosion.
It was a phenomenal jump. It's the ultimate validation of the crisis as a catalyst. Within just a 5-month period at the start, we saw an unprecedented 20 to 55% increase in the use of telehealth services across both primary and acute care.
And these were organizations and providers who were previously really reluctant to use it.
Deeply reluctant. Many had resisted the technology for years, but they were forced to embrace it overnight, simply to survive and serve their patients.
And once that effectiveness was proven on such a massive scale, it just became the new standard.
It did. And that necessity also accelerated the use of remote patient monitoring systems, mobile devices, wearables for managing chronic conditions. This ability to assess a patient's status from a distance created a whole new set of expectations among consumers.
Once people saw how effective and convenient it was, they expected to keep using it.
Exactly. The genie cannot be put back in the bottle. Its utilization is now the norm, and it has fundamentally changed consumer expectations forever.
But, the best technology in the world is useless without the human structure and collaboration to support it. Which brings us to driver 6, interprofessional partnerships.
The core driver here is the recognized need to improve outcomes for patients dealing with these increasingly complex chronic and acute conditions. As care gets more complex, requiring input from cardiology, behavioral health, infectious disease, pharmacy, the need for providers to coordinate seamlessly is just absolutely crucial.
We've been hearing about team-based care for decades, right? Going back to major reports from the early 2000s. Why has it finally become such a major driver now?
You're right, the call for team-based care from the IOM goes way back. But the pandemic, combined with the technological complexity of something like precision medicine, it made it a true necessity, not just a nice recommendation.
Because coordination is the key to achieving those 6 characteristics of quality care.
The ones defined by the IOM: care that is safe, effective, patient-centered, timely, efficient, and equitable. Operating in silos prevents timely diagnosis and treatment. Collaboration demonstrably prevents medication errors and achieves better, more coordinated patient outcomes. It's that simple.
And the crisis gave us this incredibly acute, real-world example of this partnership being built from the ground up almost instantly. You're talking about surge planning.
The surge planning efforts we saw across the globe, from New York to northern Italy, they were just extraordinary examples of deep interprofessional collaboration. It required hospital operations people who manage logistics and the physical building to integrate completely with inpatient care providers who manage the clinical side.
So they had to figure out how to integrate adult and pediatric services, shift resources, and just maximize every last bed.
And that meant involving people who, traditionally, never really spoke to each other clinically.
You mean bringing together physicians, nurses, respiratory therapists?
And supply chain experts and maintenance crews and infectious disease specialists. This collective integrated expertise is what enabled hospitals to provide efficient, high-quality care even when their traditional organizational charts were just utterly insufficient for the overwhelming volume of illness. The crisis drove these changes, and it resulted in successful outcomes through forced, deep collaboration.
So technology provided the tools, and collaboration provided the unified human structure. Now we can look at what those unified teams are actually delivering. Care tailored specifically to the individual. That's driver 7, personalized health and precision medicine.
The fundamental driver here is the rapid advance in our scientific knowledge. We now recognize that individual factors, your genetics, your genomics, your environment, your lifestyle, they all result in wildly different responses to treatments and medications.
So the traditional one-size-fits-all approach to medicine is becoming, well, archaic and ineffective.
It really is. So if personalized medicine is about tailoring interventions, the way the scientific community defines it is as a sophisticated way of segmenting the population.
How so?
Well, precision medicine separates people into distinct groups so that medical decisions, interventions, and products can be tailored based on their predicted response or their risk of disease. The Precision Medicine Initiative defines it as an approach that takes into account individual variability in genes, environment, and lifestyle.
So moving away from treating the average patient and toward treating the unique person.
Exactly. And this level of customization, as you can imagine, requires an exponential increase in data processing and analysis.
It must.
It does. And the digital revolution we discussed provides these new ways to collect high-quality data from each individual and then link it immediately to data from massive patient data pools for analysis.
And this is where artificial intelligence, AI, enters the picture.
It is. AI-based algorithms and machine learning are creating a profound paradigm shift in clinical practice.
How does AI actually enable that shift from generalized to precise care?
AI provides three things: ultra speed, incredible accuracy, and the ability to manage and analyze truly vast and complex data sets, data that no single human or even a team of humans could process in a lifetime.
So it can see patterns we can't.
It allows us to draw immediate inferences and gain a deeper understanding of what distinguishes one individual from another by analyzing these subtle patterns in their genetic markers, their lab results, their real-world outcomes. And then that information is translated into personalized risk assessments, diagnostic pathways, and treatment plans for the individual patient.
So we're talking about molecular information from next-generation sequencing, combined with real-world evidence from clinical trials, and then continuous data streams from wearables and mobile apps, all being funneled through AI.
Exactly. And AI is already actively accelerating drug target identification. It's helping to flag diagnostic patterns in imaging that are often invisible to the human eye. This vast, integrated stream of data, analyzed instantaneously by machine learning, is transforming the future of care.
So we can ensure each person gets the right intervention at the right time.
Helping patients live longer, better lives, while minimizing unnecessary and ineffective treatments.
And of course, none of this works unless the people operating the technology and applying the science are actually prepared for this new reality, which moves us to our final driver.
The crucial human element.
Let's focus on that. Driver 8, workforce competency. The underlying pressure here is this unwavering expectation from patients, from regulators, from payers for consistent, high-quality, and safe care delivered by demonstrably competent providers.
And that expectation has forced a dramatic shift in how we educate and train our professionals. The traditional model classroom pedagogy, simply counting the number of clinical hours, is proving to be completely insufficient for this complex, dynamic environment.
This is the big acceleration toward competency-based education, or CBE.
CBE is the future. It's a movement away from the input, time spent in a classroom, and toward the output, demonstrated ability.
It's about what you can do, not how long you sat there.
Precisely. It aims to capture the required knowledge, skills, and attitudes necessary for a high level of practice. And this emphasis on tangible, repeatable ability has been rapidly driven even further by technological acceleration and learning.
The pandemic forced everyone, even the most traditional institutions, to finally embrace online learning.
It did. Educational platforms opened doors regardless of physical location. But beyond just basic online learning, the real breakthrough came in simulation technology.
The lifelike mannequins.
Exactly. Technological advances resulted in these incredible mannequins that can be programmed to simulate complex clinical conditions, from a cardiac arrest to a complex infectious disease presentation.
And simulation is no longer just for, basic training for students.
No, it's used across the entire continuum. In academic programs, in residency training, for onboarding new employees, and, critically, for ongoing competency assurance for the existing workforce.
It allows you to practice high-stakes scenarios in a totally safe environment,
where mistakes can be analyzed and corrected without any patient risk. And this was absolutely essential when hands-on clinical time was so severely limited during the surge.
The pandemic also forced the creation of entirely new professional mandates, didn't it? Recognizing that healthcare doesn't just stop at a country's border.
Absolutely. We're now seeing global health competencies being developed based on pandemic learnings. Global health is defined as research and practice that prioritizes improving health and achieving equity for all people worldwide.
COVID-19 really underscored that health professionals are members of a single global community.
It requires an interdisciplinary, population-based effort to address the root causes of disease, whether that's vaccine hesitancy, supply chain logistics, or global disparity.
This level of complexity requires leaders who are specifically prepared to manage these huge systems, to synthesize all this data, and to implement innovation rapidly. This seems to be where the doctor of nursing practice, or DNP prepared nurse, really comes in.
The DNP nurse is specifically prepared to address these exact macrosystem issues. Their training drives them to think creatively, to strive for innovation, and to rigorously evaluate all areas of practice to improve patient, population, and organizational outcomes.
They are the systems thinkers.
Ones who can handle the complexity that Posavac described right at the beginning of our discussion. They bridge that gap between complex research and immediate bedside practice,
They have that unique connection to the bedside.
which allows them to identify innovative ways to provide safe, effective, patient-centered care. They are explicitly expected to safeguard quality and safety by evaluating outcomes and recommending evidence-based ways to improve effectiveness at the organizational level.
And the source material really highlights that their role has dramatically evolved. It's not just about being an anticipated partner anymore. It's about being an actual leader.
That is the key shift. The Future of Nursing report back in 2011 talked about the potential of nurses to lead, that they should be full partners.
Right, it was aspirational.
Exactly. Today, the source confirms that DNP nurses are no longer just having potential to lead or should be full partners. They are leading and they are full partners in transforming the healthcare system. Their ability to think critically about system change is now recognized as a non-negotiable requirement.
And their actions during the pandemic really proved this leadership under fire.
Their leadership during that chaos was incredible. It included preparing hospitals for surges of ICU patients, adapting standards of care instantly, supporting staff through unprecedented emotional and psychological stress.
And evaluating outcomes for a population with just drastically different needs.
Their ability to be nimble and to quickly evaluate their approach in that rapidly changing environment became the defining symbol of the needed leadership competency across the entire system.
So we have 8 interconnected drivers, from policy to precision medicine, that have just fundamentally changed the how, the what, and the who of healthcare delivery. Now, let's confront the grand challenge that ties this whole deep dive together. How do you actually measure quality in this hyper-complex, continually shifting landscape?
The challenges of evaluating quality are truly daunting, and they fall into 3 heavily overlapping, persistent areas that just undermine our efforts to know if we're actually improving.
Let's start with the first one, which is maybe the most philosophical challenge: the complexity and dynamic nature of healthcare itself.
We touched on this at the start, but it really bears repeating. Changes in health status for an individual or a population, they rarely result from a linear cause and effect relationship you can attribute to one single intervention.
Right.
Outcomes happen because of these incredibly complex, non-linear interactions among dozens and dozens of variables.
So if care is delivered by a team of, say, 10 different providers, how can you possibly isolate the specific effect of one nursing action or one respiratory therapy decision on the patient's final recovery?
It's nearly impossible to isolate that variable. Think of it like trying to determine the exact contribution of one specific herb to the complex flavor of a Michelin star soup.
Yeah.
You know it's in there, and you know the outcome depends on it, but measuring its independent effect is an intractable problem.
And because we practice in teams, it's the fundamental barrier.
It is. And because the system is so dynamic, constantly being driven by new tech, new policy, new knowledge, any evaluation we conduct is almost instantly outdated.
Like taking a single photograph of a moving train.
That's a great analogy. Any findings from an evaluation are only a one-time snapshot of quality. By the time the data is collected, analyzed, and published, the standards and technologies have already moved on.
So to get a real view, you need these expensive, difficult, longitudinal evaluations that follow performance over time.
Which demands better models and methods for capturing that sustained quality. And that leads us directly to the second problem: the maze of measures. We're dealing with an overwhelming and continually growing number of available measures, but their quality and utility are just all over the map.
Not all measures are created equal.
Not at all. To be useful, a measure has to be sensitive to the performance you're interested in, grounded in clinical science, valid, reliable, understandable, and perhaps most practically, have readily available data sources.
But if we look closely at the measures that are actually being collected across the industry, the metrics that determine funding and hospital rankings, we find this massive, entrenched distortion.
This is the core problem that Michael Porter identified way back in 2010, and it is starkly true today. The vast majority of measures we collect and report are process measures, not meaningful outcome measures.
Okay, what is the practical distinction there for the listener? And why does that distinction fundamentally undermine quality evaluation?
A process measure reflects whether the current quality standards or steps were followed. Did the nurse document the patient's full risk? Did the surgeon use the correct checklist before making an incision?
So they're about compliance.
They're crucial for compliance, yes,
Hmm.
and they're very easy to digitize and collect from an EHR. But, and this is the key, they do not necessarily correlate with the patient's final health or the organization's outcomes. They're just steps in a protocol.
Whereas outcome measures correlate with the patient's actual recovery.
Correct. An outcome measure correlates directly with patient health. Things like readmission rates, mortality rates, a patient's functional status 6 months after discharge, or patient-reported quality of life.
The measures that actually show if the system made a patient's life better.
Exactly. But because they are often longitudinal and require complex data integration from outside the immediate clinical encounter, they are significantly harder to develop, collect, and validate than simple process compliance checks.
So evaluation defaults to the path of least resistance. Measure the process, not the result.
It often does. And finally, the third challenge, which ties the previous two together, limited standards and criteria. If your measures are flawed, your standards are going to be flawed too.
How so?
Standards and criteria are what we use to judge the achievement of desired outcomes. They come from authoritative publications, organizational guidelines, core competency reports, and they must be based on the best available evidence. But the identification of useful and practical measures, which we just established is a huge challenge, is what drives the development of those very standards.
So we're caught in this vicious cycle. We prioritize easily collected process measures, which then leads to standards that value compliance over results, meaning we're ultimately judging performance based on inadequate criteria for what constitutes actual patient health.
In short, yes. The entire enterprise of evaluating quality in healthcare is a continuous work in progress, and it's widely recognized as the most complex area for evaluation compared to almost any other major field, like education. The speed of change imposed by these 8 drivers has just made the need for better evaluation methods even more urgent.
So we've journeyed through 8 major interconnected drivers, all turbocharged by the COVID-19 mega driver, which forced this rapid acceleration in policy, technology, and partnerships. And we've acknowledged this profound complexity of evaluation, highlighting that critical, almost dangerous difference between easily collected process measures and the meaningful but hard-to-capture outcome measures. It's an extraordinary amount of transformation happening at a breakneck pace.
It is, and I want to leave you with a final thought, which is built around an old expression often referred to as a Chinese curse. May you live in interesting times.
Right. It sounds like a blessing, but it's not.
It's not. The original intent was that life is better in uninteresting times of tranquility rather than in interesting times, which are just synonymous with trouble, instability, and upheaval.
And we're definitely living in interesting times in healthcare. There's no doubt about that.
We are. But here's the critical reframing. Although these times have brought trouble and chaos and some very steep learning curves, they have also brought unprecedented opportunities.
Opportunities for dramatic change.
For innovation, for leadership, and for real progress in achieving a significantly higher quality of care. The steep, forced learning curve we've all collectively experienced has made the system wiser, nimbler, and unquestionably better prepared for an unknown future.
So we've crossed a threshold, and there's no going back.
That is the takeaway. The sources make it crystal clear. Returning to the normalcy of 2019 is not likely, nor would it even be desirable. 2019 was a system riddled with the very barriers we've just spent this time discussing.
So the question isn't if we'll revert.
No. The question is how we will leverage the immense knowledge we've gained in policy, in technology, and in collaboration to ensure that future evaluations move beyond that simple process snapshot. How do we make them truly guide the bold decision-making needed to achieve desired patient outcomes for every population everywhere?
That's the challenge.
That is the necessary focus for anyone leading in healthcare today.